Hello, my name is Gerard Brennan. I am a physical therapist, a senior clinical research scientist in rehabilitation services at Intermountain Healthcare in Salt Lake City, Utah. And I'm very happy and appreciate being invited to speak with you today about what I think is the synergy of improvement science and implementation science. Improvement science takes a pragmatic approach to the reduction of poor performance in healthcare delivery. Implementation science stems from a behavioral science focus and focuses on the need to adopt new evidence into practice. The integration of these two approaches can contribute to improvement. And the two approaches really need to become more closely aligned so that healthcare providers and researchers can harness the full power of a synergistic approach that's greater than its parts. As I mentioned, I'm from Intermountain Healthcare, which is in Utah. It's a nonprofit large healthcare system. It has an integrated payer that is the largest payer in Utah, Select Health. And it's an organization really committed to delivering quality care. So implementation is kind of a new frontier in rehabilitation. It's this emerging scientific discipline that provides opportunity for researchers and clinical leaders to develop strategies to improve the quality and the effectiveness of rehabilitation with two objectives in this talk. And one is to understand the principles of implementation science, and secondly, how to use it to drive evidence-based practice. My purpose is to link these concepts of implementation science to a specific example of our work at Intermountain Healthcare. I think what you'll see is that implementation science and improvement science are synergistic, and separating them is a little artificial. So implementation science refers to the work to promote the systematic uptake of evidence-based practice interventions into practice and policy, and it focuses on the timely and appropriate uptake of that evidence. Whereas quality improvement science refers to systems level work to improve quality, safety, and value of healthcare services at a systems level. It's a pragmatic approach to reduce poor performance. It derives a lot of its science from the automotive industry, and it measures performance to achieve improvement. So implementation is the means by which an intervention is assimilated into the organization. And it really has, the implementation has two major components: the critical gateway, which represents the organization's decision, such as Intermountain's decision, to adopt an intervention, and the routine use of that intervention. There's the second part is there's typically a transition period, and this is a time during which it takes the stakeholders to become increasingly skillful and consistent and committed in their use of the intervention. Now, why are we discussing this? Because both systems of thought are aimed at improving care. But the reason we're talking about this is based on, I think, McGlynn's work and publication on where she demonstrated that Americans receive about half the recommended medical care evidence-based practices that they ought to receive. And the gap between what we know works and what's actually done and delivered is substantial and warrants attention. So how do we bridge this gap between what we know works and the care that we deliver? We have to realize that it's not a simple solution because healthcare systems are complex and they're diverse. But the key is to make the availability of information about our performance routine and easy to access So we need to automate the entry and the retrieval of key data to help drive clinical decisions and to help measure and report the quality of care, the compliance with the processes, and the measurement and reporting of the quality. So it has to be automated and routine to input the data, but we also need to be able to retrieve the data. And a lot of times that's where we stumble. So let's imagine that you're planning a change. You need to evaluate the implementation outcomes to assess the extent of the effectiveness of the effort you're putting in to a specific setting. And then to be able to assess the sustainability of that effort and whether it promote dissemination to other settings. So having done that, there's a need to measure the performance to achieve improvement. So right there, you see the synergy between implementation science and improvement science, because in implementation science, you're looking at the uptake of evidence into the population. And then with improvement science, you're measuring the performance to achieve improvement. And so you see that synergy. Now, why is implementation science important now? And it's because the healing professions are changing. When you look at physical therapy practice, we've moved from a craft-based practice to a profession-based practice. In a craft-based practice, you have individual therapists working alone, and this was much of my career, developing a handcrafted, customized solution for each patient based on this commitment to the patient. And then you have this vast personal knowledge on the part of the therapist gained from training and experience. Now what we're doing is we're moving to a profession-based practice where you have groups of peers treating patients in a similar setting. For example, low back pain. And it plan coordinated care delivery processes which the therapists adapt to individual patients' needs. Now, early data indicates that this approach is less expensive because the facility can staff itself and train and supply and organize toward a single, simple core process. It's less complex, there's fewer mistakes, there's fewer dropped handoffs, and better patient outcomes. There are 6 key points to improvement science. And that is, starting from a shared baseline to implement evidence-based practice. And what you need to do is first select a big target, select a high priority clinical condition, generate an evidence-based best practice guideline for that condition as best you can, blend the guideline into the flow of work, a standard clinical flow of work by staffing and training, having the supplies, the physical layout, that sort of thing. The 4th step is to embed a data system to track the protocol variations and to track the outcomes, the short and long-term results. Most importantly, demand that clinicians vary based on the individual patient's needs. And finally, measure, learn from, and eliminate variation arising from professionals, but retain the variation arising from observations related to the patient. The first one is to identify a high priority clinical condition. Treatment of conservative low back pain, non-surgical low back pain, this is a big, expensive, and very frequent clinical condition in our system, and it had a substantial failure rate, failures of care. So we knew that this was a compelling place to start for pay for quality incentive with physical therapists and patients who had low back pain. Low back pain had a high probability of engaging the payer, the provider, and the patient. And so this was our starting point. The second step is to build an evidence-based practice protocol as best you can. And so here you see the example that we used in our training of a flow chart for the treatment-based classification of patients with low back pain. And so it's a series of questions. Do you have a nerve root compression? Yes, you go down this side, left. No, you go down the right side, okay? So does the patient have a nerve root compression? Does your patient centralize with extension or peripheralize with flexion? And over on the right, no, they don't have a nerve root compression. Do they centralize? Do they peripheralize? Do they have symptoms of short duration? No symptoms distal to the knee, then you manipulate it. So it kind of guides the therapist in an algorithm setup as to how to evaluate the patient. Then you blend that into your clinical workflow. And in blending the guideline into standard clinical workflow, you support that process with how you design the EMR. And so for the manipulation classification, here are the characteristics. You see the characteristics, and for specific exercise, the characteristics, and that sort of thing. So the electronic medical record supports a standard clinical workflow. So let me explain to you the fourth step, how to embed a data system to track outcomes. So measuring the process compliance with low back pain treatment-based classification system was a project that Dr. Minnick and I worked on. And the purpose was to measure the therapist's compliance with the standard workflow to evaluate patients with low back pain using the treatment-based classification system, but also to assess the effect of compliance on reducing the failure rate of care. Now, failure rate was defined as the proportion of patients who fail to achieve a minimal clinical important difference on the modified oswestry. In order to do this, you need infrastructure to gather and store the measurements. We used ROMS, the Rehab Outcomes Management System that we have at Intermountain. So you have to create an infrastructure, and then you have to track the process of care and the outcome. And finally, you need to make it possible to assess the effect of local efforts to improve quality. So you have to make it possible for locally for clinicians and patients to assess the effort to improve the quality of care. And that means the data is perceived to be meaningful and detailed enough so clinicians think that it's justified. And this was the key point in relating to the Pay for Quality project. So you have a standard care process. Now you need to measure whether you perform the key processes. So what we did was we took that algorithm that you see on the right, and we developed an Excel spreadsheet, and each column represents one step in the algorithm. So first, over here on the left, does the patient have nerve root compression? That's right at the top of the algorithm. And then the next question is, does the patient centralize with repeated extension? Well, if they do, then the classification is specific exercise extension. And so you go through this step by step, okay? And each one of these steps is a lead measure. And if you follow the lead measures, you really impact the lag measure. The lag measure is the failures of care, the percentage of patients that fail. Okay, we're trying to reduce that. But just looking at that after all is said and done is not very helpful to a therapist. But if they see in real time whether or not they are completing the evaluation properly at each step, that's how you improve. So the lead measures relate to the lag measures. In implementation science, we talk about inner setting and outer setting. The inner setting has to do with the structural, political, and cultural context through which the implementation process occurs. So in our example, the therapists were being re-educated on the treatment-based classification system through online measures at the start of 2017. And we measured whether or not they did this, whether they went through the educational modules. And then we developed a quality review tool, a scorecard in Excel to standardize the chart audit. And that was piloted with 20 charts, 5 reviewers, test reviewers. And then we refined that review chart with 7 reviewers, and we had 7 reviewers complete a 90-minute audit training so that we standardized the process of the audit. The outer setting is the economic, political, and social context. So the outer setting involved the pay for performance program that we had as incentive for physical therapists that was supported by the payer, Select Health. And then therapists were taking the clinical outcomes that were being in those measures of performance, they were incorporating those measures, their failure rate, into their job performance reviews. And then, you know, we had the whole effect of all our peers' opinions of the leadership of rehabilitation and the overall level of professional engagement. So each reviewer, the 7 reviewers, completed 20 to 22 charts each quarter using the EMR. And if the reviewer had questions about making a decision, what they did was email the other 6 reviewers and say, what would you do on this? What do you think about that? And that helped them resolve with group consensus. Compliance was defined as the therapist making a correct classification, and secondly, matching the first treatment to that classification. Then we used a chi-square to measure the association between the classification and compliance, and as well as the compliance and the failure to progress rate. So and then results for each clinic were compiled and disseminated to clinic managers. So you can see this synergy between principles of implementation and principles of improving performance or quality improvement. This is what the scorecard looked like. Over here, you have the patient's MRN number, okay? And then you have, was the correct classification made, specific exercise extension? Well, the therapist classification was the same, specific exercise extension. They went through each step, they got to that decision, they made the right classification. Was it correct? Yes. Did the classification and the treatment, were they adherent? Were they on protocol? Were they matched? Yes. And overall, what was the total compliance for, you know, everyone? And this is about 62.5%. So you can see that we had some work to do. And so here's an entire Excel spreadsheet where we measured everything in the all the audits in the 4th quarter of 2017, and it's about 56% total compliance. Now, when you look at this, the low back pain process compliance graph, what you see is that in green, I've boxed the 6 clinics that delivered the standard work correctly 100% of the time. So it can be done. 6 more clinics did it at least 80% of the time, but not 90% of the time. And 10 of the clinics, a third of the clinics, didn't do it at least 50% of the time. So, you know, the payer didn't want to pay any incentive to, regardless of the outcome, patient to a clinic or therapist that were not at least following the process of care accurately 90% of the time. So what you see when you look at 2017 4th quarter And then second quarter of 2018, we went 57% compliance, and we improved 5% to 62%. But when you look at how we decreased the level of incomplete charting, we went from 29% of people that did not complete the process to just under 20%. So almost a 10% improvement in following the process correctly. And in quarter three, I can just tell you, we improved to 63%, 62.6. So it was sustainable. And by quarter four, we were up to almost 69% as being compliant. And so, the process was working. And here where you see the second part of our goal, when you look at quarter four in 2017 and quarter two in 2018, you see that when we matched the patient in the classification process, when we matched them correctly, they succeeded in achieving a significant clinical improvement, significantly more than when they were not matched. And so we measured the results, we measured the outcome. How does this example illustrate the synergy of implementation science and improvement science? And again, in the implementation science, we're working to promote that systematic uptake of evidence. And I explained how that worked with training the therapists. And we focused on the timely and appropriate uptake of the evidence. So we measured whether or not they did the training in a certain period of time, because we could measure that electronically. We could see whether the therapist went through the modules. In improvement science at a systems level, to improve the quality, we measured the quality of care and the value. We measured the performance to achieve it. So we measured what I just explained in terms of the percentage of patients that achieved significant clinical improvement, and whether or not they complied with the process of completing the steps. So how does this example illustrate the principles of implementation science? Well, the two components, gateway and transition period. The gateway, you saw that we made a decision as a rehabilitation division to implement and measure the process. And then there was a transition period where we had to train everybody. So that represents the time for therapists to develop the skill and the consistency and the commitment to the process. We're measuring it and we're feeding back that information to the therapists. And then we evaluated the effectiveness locally and across settings to demonstrate that the process was sustainable and could be disseminated. So, clinics were able to see that other clinics were doing it and that it was achievable. And then in terms of implementation, you think about deployment. We considered the inner settings, the factors related to the context of the inner setting, the structural, political, and cultural, and the outer setting, the economic, the incentive program, the political context of working very closely with a payer. Not many physical therapy groups get that opportunity to work closely with a payer. And then the social context of, how does it affect, staff morale? And do they feel like they're working in a professional environment where they can establish a career versus just, I've got a job? So that's, I think, what's illustrated in that in terms of implementation science. So thank you very much for the opportunity to share these ideas with you, and contact me by email if you'd like. This is a picture of a ski day at Alta ski area, and a picture on the right of Zion National Park from Observation Point. Thank you.